Good evening, all. So sorry for the delay. So I welcome you all, and I am just introduced that Dr. Ranjith, speaker of the today's session, and he is actually my senior from JIPMER, and he did his MD DNB from Kanchkamkoti Children's Hospital, and then he got his DM Medical Oncology from JIPMER, and then he did postdoctoral fellowship in pediatric hemato-oncology and bone marrow transplant from Tata Memorial, Kolkata. Then he's currently working in AOA Hyderabad as a transplant physician. And the most important thing is he is doing transplants not only for the cancer conditions and mainly for non-cancer conditions, pediatrics like thalassemias, primary immunodeficiencies, osteopetrosis. So you name whatever. If the disease has a option of transplant, he can do the transplant. It could be matching, half matching. So you don't worry. If you have a patient who is eligible for transplant and he has an at least half matching donor, he can do it. So that is the capability of him. So with this brief introduction, he's a very good speaker and he's an academician. So we'll over to you, sir. Please take over.
Yeah. Good evening, dear friends, and Ramarao sir also. So today we will discuss about the common topic, which is like the CBC. CBC is one of the extremely important entity for your ASCII in the DNB as well as for the day-to-day practice also. The one most important thing when you are actually interpreting CBC, you must know some differential diagnosis. So means like if your brain does not know what you are actually looking at, your eyes cannot see. That's the most important thing for any of, particularly for the physicians, because unless you see some of the signs in the child when you are examining, or some of the laboratory tests, if you don't know how to interpret it, it is no use. So with that brief introduction, yeah. So today we will discuss with this headings, understanding of the CBC report, because like what are all the parameters a CBC report should have, and what is the normality as well as abnormality, and we should know always common differential diagnosis, and when to take an expert opinion and suggestions, and what are all the approaches. So these are the under these headings we will discuss. And so we all know that probably like in the 1950s and 60s, our seniors would have seen the CBC such a so difficult way to interpret the counts in an individual. Now we all have a luxury of technology with a minute time. Probably like once if you load the blood sample, 2 drops of blood sample, probably you are getting the reports at this point of time. So probably we all might have seen this picture. Yeah. So you all would have seen in your physiology lecture in the first year of MBBS. This is called as the newborn chamber. And through this, they used to do the differential counting. And so a typical CBC will looks like this, which should have the numerical parameters of the various cells, and also the same thing which will be represented in a graphical way in this manner. So you get in a mission the counter, which the mission called as Coulter mission. The Coulter mission CBC will give these 2 parameters. One is the numerical value of each cell line, and also the graphical representation. Both are important for us as a physician, because if you start looking at these graphs, which is these graphs are extremely useful, particularly during the transplants. I use these graphs in a very much, because these are very simple graphs to understand. These are very useful. You also know, particularly if the child is recovering from a dengue or some viral infections, these graphs will help you rather than this one, because this is just a numerical representation. But here, if you look at these graphs, they give a lot of information. So the CBC, we all know, probably it is the most common test to order in any medicine. And it is one of the first tests to be ordered by any physician or surgeon. but it is a single most important investigation, which is very inexpensive. Probably it will cost us lab to lab cost around like 40 to 50 rupees. If you are actually adding the extra parameters like immature platelet fraction and also like reti count, your cost may go up to 100 rupees, not more than that. So such a simple test, inexpensive test, will give us a lot of information um, in the clinical practice. So we all should know like what is basically CBC, the definition of CBC. So CBC is nothing but we are actually studying the composition and concentration of a various cellular component of the blood. So we have various cellular components in the CBC. So we are going to study those things. Nothing but a CBC. So which consist of three parameters predominantly. Under the three parameters, we will have the sub parameters for the each cell line. So which will give the information about the red blood cell, which will give information about the white blood cells, and also the platelet count. The subsequent parameters are related to the RBC, WBC, and platelet count. For example, if you see the previous slide, here if you see, you have a WBC and the RBC and the platelets. These are the three things. The other parameters are basically the derivative of the each cellular line. And so the counter mission is basically works by the principle called impedance technology. What is the meaning of impedance? Through an aperture, any particle, if it is passing through, based upon the size of the particle, size of the cellular particle, or the granularity of the particle, the light will get distracted in the various directions. So based upon that, they actually like the prepared the graphs. And if you see this particular graph, basically the impedance technology will be particularly useful for the differential count, not for the RBC and platelets. So this mission was invented by a engineer called the Poulter. That's why the name Poulter mission came. And if you see this particular the graph, this is basically the based upon the size and the granularity. This graph has been prepared. So the smallest cell WBC in our body is the lymphocyte. So the lymphocyte parameters will come near to the X and Y axis joining place. Then the middle part is, this is called as the middle part. This middle part, probably we will see the monocytes and the large lymphocytes. Whereas the large cells in our body is the neutrophils and eosinophils. Here we see the neutrophils and the eosinophils. So if you understand this graph, which is very easy, when a patient is recovering, for example, a child will come with the viral fever. They might be having a neutropenia. So what will happen? The graph, which is supposed to be shown here, will be depressed. So probably you will see, instead of the curve like this, you will see the curve like this. But the child might be having a normal WBC count. So probably like your lymphocyte parameter might be increased. So apart from this one, the advanced counter missions also give us the information like red flag signs, such as the blast population and all. So these are the advanced counter missions will give the information. Probably like most of the laboratories nowadays, we are having the 5-part counter mission. Three-part counter mission will give the, so the what is this 3 and 5 you must know. The 3 and 5 is nothing but the number of the differentials. Means like for example, in the WBC compartment, if you see, we have a neutrophils, lymphocytes, eosinophils, basophils, and monocytes. So, and then of course blast population also. So if the information, if the counter mission is giving only the 3 cellular information like a lymphocyte, monocyte, and neutrophil, we call it as a 3-part counter mission. If it is giving the 5 cellular component, we call it as the 5-part counter mission. Of course, we are having an advanced counter missions like the 8-part and 10-part counter missions also at this point of time. But for the routine clinical practice, at least the standard of care based upon the NABL accreditation, you must have a 5-part counter mission. So these are the differences between a 3-part counter mission and the 5-part counter mission. The 5-part will give the information, even the basophils, eosinophils also. Whereas the 3-part confirmation will give the lymphocytes and neutrophils and the mixed cells, means the other cells all clubbed together and you will read actually. So this is the basic difference between a 3-part and 5-part confirmation. Of course, the 5-part confirmation is very means like little expensive to manage, means for the maintenance of the 5-part confirmation will take little more extra cost for the lab, but it will give a lot of information which will give almost like 33 parameters, whereas 3-part confirmation will give only the 18 parameters. Why these things are important for us? Because as a physician, if you don't know what the machine is giving, if you are not able to understand, your interpretation is not correct, probably we might not be labeling the patient's diagnosis appropriately. So before actually like sending the sample, the most important thing is the pre-analytical errors. These are extremely common because, for example, if you are sending the sample, you are collecting the blood, the ratio of the blood to your anticoagulant, which is not appropriate. And at the same time, you are not sending the sample in an appropriate time to the laboratory. Your values may be wrong or it may deviate. So before actually sending to the lab, because most of the times there's always a conflict between a physician and the lab personality. I will send the sample, we always will say our sample we have sent appropriately, your mission is wrong. So let us actually like first and foremost thing is what we have to keep in mind as a physician, we must send appropriate sample to the laboratory. So the sample should be checked, it should not have any clots visually, and most important thing is once you have sent the sample, it should be basically like processed within the 8 hours, but not more than 24 hours. So that's the most important thing. But I think now in India, the kind of growth which we are seeing, I think most of the even the mandal headquarters also we are having the counter mission. So this problem I think we are not facing at this point of time. But most important problem which we are facing is the checking for the clots. We always will miss it. The moment we collect the sample, you need to at least shake the sample for at least 3 to 4 times. Then only anticoagulant will be well mixed with the blood so that there won't be any clot formation. If the clots are formed, so what you are going to get, you're spuriously going to get the low platelet count because of the clumps. So again, you will have a problem. So you have to send the adequate sample and also the well collected sample to the laboratory for a good analysis. This is extremely important. Pre-analytical errors are extremely important. So keep in mind whenever you are actually sending the sample. So as I discussed previously, the 3-part confirmation, 5-part confirmation, as I told, these are the various RBC parameter a machine will give. And in the WBC compartment, these are the various parameters the machine will give. And platelet compartment, these are the values it will give. So a 5-part confirmation will give about 33 parameters. Now we will see the one by one RBC related problems, WBC, and also the mixed problems also. So before actually going to the main discussion, we must know like what is the normal physiology or normal count of an individual. So we all know that the anemia, like the hemoglobin concentration at birth, it will be like around like nearly 18 to 20, but by the probably like 10 or 15 days, it will become stabilized at around like 11 to 13. So these are the various normal hemoglobin values and also normal MCV values of the in a human. So the before actually like going for the main discussion, you must know what are the various definitions of a CBC. So in the RBC subset parameters, you will have a MCV and MCH and MCHC. So what is the meaning of the MCV? It is basically an average volume of a red blood cell. So based upon this one only, we have a anemia classification. And MCH is basically hemoglobin concentration in a single red blood cell. And MCHC is basically an average hemoglobin concentration per unit volume. Let's say, for example, deciliter called as 100 ml of the packed red blood cell, which is indicated by the MCHC. So these parameters are extremely important if you are actually dealing with a child with the anemia. And reticulocyte count, of course, extremely important. Always reticulocyte count, don't calculate blindly. You need to always look at the hematocrit of the patient. if the patient is having anemia, because most of the times reticulocyte count we will be utilizing mainly for the cases when we are actually looking at anemia. So if the child is having anemia, always you need to correct for the normal hematocrit. Then only the appropriate reticulocyte value will come. So these are the minimum 4-5 definitions you must know before actually looking at a child with anemia. So what is reticulocyte? We all know that before the mature RBC, the prior to that, the cellular component we call it as a reticulocyte, which usually spend about like 2 days in the bone marrow, but which also circulate in the peripheral blood for 1 to 2 days before actually becoming the mature RBC. Usually, like normal value, we see about 1 to 2% in the peripheral blood, but it should always be corrected with the hematocrit before actually you are giving the reticulocyte index in the report. So the what is the information reticulocyte will give us? We are basically looking at the bone marrow activity. It is basically a window to look at the bone marrow. So based upon the reticulocyte count, we can say whether the bone marrow is functioning well or not. So the coming to the anemia classification, as I told, whatever the RBC subset parameters like MCV, MCH, and MCHC, the most important parameter to divide the anemias into the various classes is the MCV. So what is the normal MCV? Remember, in a simple manner, 80 to 100 is the normal MCV. Anything less than 80, we call it as a microcytic. Anything more than 100, we call it as a macrocyte. So this photograph you must have seen in the textbook of neonatology. Sorry, in the Nelson textbook in the neonatology chapter. Basically, like a globin chain transformation in a human life. So if you see, normally like the neonatal RBCs will be having a lot of like fetal hemoglobin. So nothing but they will have a gamma chain. This will be transformed into the adult hemoglobin at about like 6 months of age. So that is the point which you have to keep in mind. That's why neonatal RBCs are having a predominant like high MCV compared to that of the mature RBC. So based upon the MCV, we classify the patients into the microcytic or normocytic or macrocytic anemias. The normal value is 80 to 100, you should keep in mind. Less than 80, we call it as a microcytic. More than 100, we call it as a macrocytic. And then the next important thing is the RDW. So what is RDW? RDW is nothing but various sizes and various shapes of the RBCs. It will be thrown into the peripheral system from the bone marrow if there is any insult to the bone marrow. So nothing but RDW, simple terminology, it is basically a numerical expression of anisocytosis. What is the meaning of anisocytosis? Various sizes of the RBCs, if they are coming to the peripheral blood from the bone marrow, if the bone marrow is trying to produce the more number of the cells, those cells will be in the various size and various shapes. So that information will be given in a numerical manner is called as the red cell distribution width. So it's nothing but the quantitative measurement of the numerical expression of the anisocytosis. Why this is important? So basically to differentiate between iron deficiency anemia and thalassemia trait or other hemoglobinopathies, red cell distribution width will help us. So the normal red cell distribution width will be 11 to 14, you can remember. Usually in iron deficiency anemia, the first thing which is changing in a CBC is the red cell distribution width. Even before your ferritin values goes down, your red cell distribution width will change. This will be easily picked up in the histograms. As I told you, once if you are actually looking at the histograms, it's very easy whether this patient is actually going to develop the iron deficiency anemia or not. They might be having a low normal ferritin levels, then we will actually just tell them, no, your hemoglobin is you doesn't have any iron deficiency, and you can we are actually we are going to miss this iron deficiency. So by looking at these graphs, the mission gives, we can actually pick up early based upon the RW. Of course, RW will be given as numerical value. If it is the more than 14, that is the first parameter which will change the iron deficiency anemia. And this slide, I think every physician, every pediatrician must have in his office practice if you are actually looking at the children with the anemia. Always anemia, as I told, we will be categorize the patients into the based upon the MCV, microcytic, normocytic, and macrocytic. And also another important parameter is the red cell distribution with them. So the simple way to remember is MCV is low, that is microcytic, and RW, which is increasing. So we can actually, we all know that it could be probably we are actually dealing with iron deficiency anemia. Okay. So in the case of particularly like thalassemia trait, what will happen? REW would be normal and MCV will be low. So these are the two important parameters you must know. Then we will actually discuss a case now. This is a 7 years old female child, developmentally normal, previously healthy child, brought with the complaints of decreased activity for about 3 months duration, progressively pallor, and also give the history of the excessive rice eating. This is one of the typical history for the pica. We all know that. So what further history you must require? We should ask what is the diet of this child. Most important thing is, and other important information what we need to ask is there any like the nocturnal sleep disturbance is there or not? Basically to find out any worm infestation or any bleeding manifestations. So this child was asked these informations: the bleeding, fever, exertional dyspnea. Exertional dyspnea is basically to find out that the child is having any underlying anemia, and the stool habits and worms in the stool and school performance. Basically, they will have a school absenteeism and the decreased school performance. So on her physical examination, she was found to have a pallor. She has a chylonychia, just palpable liver, spleen 2 centimeters over there, and no lymphadenopathy. So this was the typical the CBC of this child. If you see, WBC count is the 6,900, and hemoglobin is 9.2. Platelet count is 3 lakhs 13,000. So if you look at this picture, RWBC, it is a 16 here. So this is the first parameter which will change. Even if you see this histogram, normally, I know this is difficult. If you are actually keep on looking up these graphs, it will be very easy. Normally, this will be closer, this peak will be very closer to the 100. But here the peak is actually moving towards the left direction. So probably the more number of the smaller cells, we are actually like looking at the smear. So probably we are actually dealing with the microcytic anemia, because here if you see MCV is just 60. So this child is having a anemia with a raised RAW, and MCV is also low. So based upon this one alone, if you don't have a ferritin values in your laboratory, if the ferritin test will take a lot of time, or if the patient is unaffordable for the ferritin, based upon only the CBC, you can actually give a trial of iron supplements for these kids. And here, if you see the lot of microcytes and also like the central pallor you can see. So based upon the central pallor, how can you decide whether this child is having a iron deficiency anemia or anemia in the sense? So we always compare the red blood cells with the small lymphocytes, because in the graph these are the RBC. Then among the WBC parameters you see the lymphocytes, and so we always compare with the small lymphocytes. So if the central pallor, normally it is 1/3 of the cell size is the central pallor. If it is increasing beyond the 1/3 of the size of the cell, probably you are actually dealing with the anemia. So the central pallor, all these RBCs are having more than 2/3 of the central pallor is there. So this child probably you are actually looking at the iron deficiency anemia. And so next important thing is, whenever you are looking at the microcytic hypochromic cells, then you need to know what are all the differential diagnosis you must know. And then how to differentiate the various differentials based upon the various clinical parameters. So these are the some of the common differential diagnoses for the microcytic anemia: iron deficiency, thalassemia, sideroblastic, lead toxicity, hemoglobin E trait, A transfer anemia, A ferritemia. These are the some of the differential diagnoses. And how the CBC will help to differentiate the various microcytic anemias, we have already discussed. Based upon the MCV and RAW is extremely important to differentiate the various microcytic hypochromic anemias. And what is other test you should do for the iron deficiency anemia to confirm? One is the ferritin. Of course, the ferritin has extreme variability with the background inflammation. Now, the one of the important tests which is coming up is the hepcidin. Hepcidin usually does not change with the inflammation. Probably like in another like a couple of months, this laboratory modality might be available for the routine clinical practice for everyone. So which does not change with the inflammation. So hepcidin will help us to basically differentiate iron deficiency in a very clear manner. So this is the slide is important for us to differentiate the various microcytic hypochromic anemias. So just keep in mind in the sideroblastic anemia and iron deficiency anemia alone, your REWs are very high. So, and how can you differentiate sideroblastic anemia and iron deficiency anemia? The most important thing is the peripheral smear. Because RBC will have a dysplastic morphology in a sideroblastic anemia, whereas iron deficiency anemia, dysplastic RBC, we don't look at it. So that's an important differentiation. And so, as I told you, REW is the first one will change in the iron deficiency anemia. Increased REW combined with the low MCV distinguishes the iron deficiency anemia from the non-anemic, basically thalassemia trait. So, REW is the first one to change in the iron deficiency anemia. And of course, to differentiate iron deficiency anemia and thalassemia, we also have various indexes. The common index which commonly used in clinical practice is the Medger index. Another index is the Srivastava index. Any index you can use, but keep one index for your familiarity purpose. The Medger index nothing but the MCV bar RBC count. What this index will give information. For example, if you are actually dealing with the microcytic anemia, common differentials are iron deficiency anemia and thalassemia. What will happen in thalassemia? In the thalassemia, the problem is not with the factory, means the bone marrow is functioning well, whereas the RBC lifespan is less. So, for example, let's say normal RBC lifespan is 120 days. Thalassemia children might be having a RBC for about like 70 to 80 days of lifespan. So, they have a more of a peripheral destruction. So that's why the bone marrow tries to produce the more number of the cells. So there will be a disparity between the hemoglobin and the RBC count. So they might be having the hemoglobin of 6 and 7, but the RBC count, you can see the 4 millions, 5 millions. So that's where like the bone marrow is trying to compensate to produce the more number of the RBCs. So if you calculate the MCV bar RBC count, if the ratio is coming less than 13, probably we are actually looking at the thalassemia trait or heterozygous thalassemia. If it is more than 13, we probably like dealing with the iron deficiency anemia. So you need not do even the ferritin value also based upon the simple minor calculations. Probably you are going to reduce the cost to the patient and also treating the patients effectively. This second case, you see, this child came at 1 month, 25 days old child, born by the normal vaginal delivery to a non-consanguineous parents. And during the vaccination, this child was found to have a dull and lethargic, decreased feeding, and become very fair-skinned. So on examination, pediatrician he found to have some polydactyly here, and also it is there in the lower limbs also. He had a grossly pallor and he didn't have any organomegaly. So very young child, probably like infant, less than 3 months old, when they present with very low hemoglobin. And apart from the some morphological phenotypes, so we have to have some differential diagnosis. So this child, when he presented, his hemoglobin was 2.8, 6,900 was the WBC count, 5.3 lakhs was the platelet count. So this is the critical value. So always the critical values, the lab should inform to a clinician. And what do we do the next? Do we need to do the immediate blood transfusion for this kid? Or can we take the sampling for the investigations and then the blood transfusion and refer to the higher center? Always as a pediatrician, what we must do, at least we should take one EDTA sample and one heparin sample. If the child is having a features suggestive of the cardiac decompensation or cardiac failure, do the transfusion, but that too you have to give the low Aliquot transfusions, not the regular Aliquot transfusions. If you are giving the regular Aliquot transfusions, probably we might be pushing the child in the cardiac failure and they will be land with the pulmonary edema. So this child, another RBC indices, if you see, he had a MCV of 109, MCHC is normal, and MCH is also normal. Retic counts are extremely low, 0.2%. So for the kind of the hemoglobin he has, if the bone marrow is functioning well, probably I would expect the retic count probably 10 to 15%. But he has a just 0.2%. REW is also within the normal range. So how to interpret this CBC? So this child is having anemia, macrocytosis, and reticulocytopenia. So he is having a, which is normocytic anemia with reticulocytopenia with normal RAW. So that is the interpretation. What should we do? What is the differential diagnosis we should have when a young child less than 3 months old presenting with the anemia reticulocytopenia without any fever? So one is probably we are dealing with the inherited bone marrow failure syndrome, or we might be dealing with the parvovirus B19 infection. Of course, parvovirus B19 we routinely won't see in such a small child unless they are immunocompromised. So what do we do? Because your MCV is extremely high. Of course, we always think about the macrocytic anemia. We will do vitamin B12 level. Another entity, what we can see such a high MCV. Of course, like retic count will be high in the vitamin B12 deficiency. Imerslund Grasbach syndrome, they usually present at a very young age. I have seen at least like 3 to 4 cases presenting around like 3 to 4 months of age. Of course, like thalassemia presenting at very young, 3 to 2nd month or 3rd month is extremely rare. Probably like we will see if the maternal hemoglobins are also very low. That is the point where probably we can see these kids might be having a low hemoglobin. Otherwise, thalassemia children usually present around like 7 to 8 months of age. This is the peripheral smear of this child. If you see a lot of macrocytes are there, and pediatricians did the bone marrow for this child. He was found to have erythroid series are markedly reduced and other lineages were normal. So probably we are actually dealing with the pure red cell aplasia in this kid. So the pure red cell aplasia is one of the outcome, but we need to look at the what is the entity we are dealing with. HB electrophores found to be normal, vitamin B12s are normal. So this young infant having anemia, macrocytes, normal RW, thumb anomaly, reticulocytopenia with a reduced erythroid lineage. So if you see here, what are we dealing? Probably we are dealing with the inherited bone marrow failure syndrome. So this photograph is extremely important when you are actually dealing with the anemia child. So again, this is another algorithm. If you see here, somebody is having a high MCV, reticulocyte count, you will see reticulocyte count is extremely low. And then you look at the white cells and the platelet count, normal white cells and platelet count, you're probably looking at the pure red cell aplasia. One entity is the diamond blackman anemia is the most common, and another entity is the TEC, transient erythroblastopenia of the childhood. They usually present around like the 4 to 5 years of age. So this is how these algorithms are extremely important for us. So this child is having a diamond blackman anemia. So how to treat diamond blackman anemia? You have to give initially blood transfusions. You can actually try a trial of the steroids because it is a ribosomal defect. Ultimately, you need to do the stem cell transplantation for these children. And the next child is a 16 years old male adolescent boy, beta thalassemia major, regular transfusion support and chelation therapy since early childhood, having a short stature and delayed puberty, presented with the increased frequency of the transfusion requirement. Instead of 3 weekly transfusion, he was taking the weekly one transfusion. This is his CBC. If you see, hemoglobin was 7.4. WBC count is at 2,800. Of course, normally we expect around 4,000. It's a low normal WBC count. His absolute neutrophil count was fine. He had a low platelet count also. And his MCV is normal range. MCH also little low, but MCHC is normal. And mean platelet volume is 9.7. I will tell you what is the mean platelet volume later. And he was afebrile, he has a pallor, and hepatosplenomegaly was there. So how to interpret this child? He is having a too frequent requirement of the blood transfusion. And of course, he is also having a defect in the two other cell lines also. Means he has a low normal WBC count and also low platelet count. That is moderate thrombocytopenia he is having. Of course, other RBC parameters are normal. And so what is our differential diagnosis? So a thalassemia child was on the regular transfusion. Suddenly he is taking more number of transfusions. So probably we might be dealing with the either the hypersplenism or alloimmunization. Because alloimmunization will cause a lot of the allo antibody formation. They will probably might be causing the anemia too frequently. So this child probably we might be dealing with alloimmunization, hypersplenism, and intercurrent infections. And what further investigations we need to order to basically label this child is having alloimmunization hypersplenism. So we need to look at the LFT. Basically, is there any hemolysis there or not? What will happen whenever actually like when you are actually dealing with the hemolysis? You must know as a physician One, and you have to document the indirect hyperbilirubinemia, and you should have a very high retic count. Your haptoglobulins must be less than 10. These are the three important things you have to document whenever you are dealing with the hemolytic anemia. So this child had a indirect hyperbilirubinemia, very high LDH, had a strong positive DCT, and haptoglobulins were less than 10. Serum ferritin, of course, was very high. B12 and folate was normal. So he had a probably like combined allo immunization because DCT was strong positive and also like hyperspinism picture. So to prove the allo immunization, we need to do again minor ABO incompatible antibody testing also, because most of the times we might be checking only for the major incompatibility ABO, but minor incompatibility we don't check. So this child had a anti-C and anti-Kel antibodies he was having. So we gave him some dose of steroids and IVIG, and then we did a splenectomy. Post splenectomy, this child is now almost like 3 years. He just take the transfusion every monthly once. And so this is the another child. If you see, these are the two children I am just comparing here. This is a 13 years old male child, transfusion since 7 months of age, hepatosplenomegaly. And this is a 7 years old female child, blood transfusion in 6 months, hepatosplenomegaly. If you look at the CBC here, this first child is having a 4,700 WBC count, another child 6,300, hemoglobin of 9.7 and 8.3. MCV, if you look at here, the MCV is normal, whereas here the MCV is 69. And other MCH and MCHC is normal, whereas the RW is also within the normal range. And the peripheral smear is the most important thing. Here you could able to see the sickle RBC, whereas here the pathology has given the target cells, clear drop cells, and polychromasia. So why I just kept this slide is basically if you are actually dealing with the sickle cell anemia and thalassemia, just at looking at the CBC, which will help us to differentiate the thalassemia and sickle cell anemia. So you don't even require the peripheral smear if you don't have a pathologist. Most of the sickle cells are normocytic, whereas the thalassemics are microcytic. So to show the difference, I just kept this slide. So the sickle cells will have a normocytic anemia, whereas the thalassemics will have a microcytic anemia. So the sickle cell anemia and sickle beta thalassemia or sickle cell anemia, these are the various differences. They might not have a splenomegaly because of autosplenectomy, whereas a sickle thal will have a splenomegaly. They are normocytic, they are microcytic, and of course, if you are doing HP electrophoresis, these are the minor differences. And this is another patient, 18 years old female adolescent, symptomatic since 15 years of age with a frequent pain in the chest and limbs. She was actually requiring the blood transfusion so far 4 to 6 times. And she had admissions twice because of the SOB and chest pain, had a limping gait, admitted for the several times for the right shoulder pain. She was having a pallor. She was short stature and underweight, no any lymphadenopathy and hepatosplenomegaly. This is her CBC. If you look at the CBC, she's probably not having much of anemia. 11 is the hemoglobin. If you see the MCV, which is normocytic, and WBC count is fine, and platelet count is also fine. So this child is having a, of course, like female children in our country, as per the definition, less than 10, we call it as the anemia. This child is having 11 is the hemoglobin, but if you look at the peripheral smear, she was having occasional sickle cells. And HB electrophoresis, when we did, we found have a sickling was positive, and she was labeled as a sickle cell hemoglobinopathy. So this is are the X-rays. If you look at the X-ray, you can see like a AVN picture, and also here like early development of the AVN. That's why she was having a limping gait. So how to manage? You have to give hydration, pain control, hydroxyurea basically. So hydroxyurea, why we give in the sickle cell anemia? Basically to improve the hemoglobin F percentage so that they don't have much of painful symptoms. Of course, you need to do the vaccination. So why I kept this slide was whenever you are dealing with the thalassemia, how to manage the pain and when to give the hydroxyurea. So hydroxyurea you have to give for every child more than 2 years if they have a frequent pain symptoms. And sickle cell anemia, thalassemia differentiation based upon the CBC is the MCV will help us. So this is the next case, 17 months old male child born to the normal vaginal delivery, non-consanguineous parents. He had a delayed umbilical cord fall, broad with the fever and perianal abscess for the 2 months duration. He had a culture of Pseudomonas, blood culture of Pseudomonas. This is the CBC. if you look at this CBC, and this first CBC is having a very high WBC count, 73,000, whereas the hemoglobin is 8.9, platelet count was the 5,66,000. If you look at the MCV, he has a less than around like 80. So probably still he's not actually having a so significant microcytosis. But this case I kept mainly for the to distinguish the basically like WBC related problems. So here this child is having a 73,000 count are there. So if you look at this graph here, as I told you, the first one is the lymphocyte graph. Second one is the lymph monocyte and basophils eosinophil. And third one is the last one is the neutrophil related problem. So basically looking at this one, even if you don't have a differential count also, you can able to say this child is having a neutrophilia. So of course, if you see the differential count, he has 78% of the neutrophil count and 58,000 is the absolute neutrophil count. And so what we are dealing with this in this child, delayed umbilical cord fall. So probably we are actually dealing with the leukocyte adhesion deficiency. So this child was presented with the infection. After treating the infection, WBC count was came down. So one more important point which I would like to enlighten here: what is the WBC and what is UWBC? You might have seen. So UWBC is nothing but uncorrected WBC. What will happen? For example, if you are actually dealing with a child who is having a anemia and also uh, this kind of like spuriously high counts, that is called as uncorrected WBC count. What will happen when we are dealing with the hemolytic anemia? The most of the broken RBC or like created RBCs will be read by the counter machine as a WBC. That's why you need to ask for the peripheral smear corrected WBC count, because the counter machine probably will give us 17,000, 18,000 WBC count. But by looking at the smear, all those high WBC count are in fact RBC, broken RBC. So that's important thing you have to keep in mind. The uncorrected WBC, that's why the machine will give. And this young child with a delayed umbilical cord, as I told, this child was having a LAD deficiency. So we did the transplant. He's doing well at this point of time. And yeah, so this, basically to see the graphs, I just kept these slides. And another important thing is here is how to differentiate the leukemite reaction versus leukemia. Because most of the times we might be seeing the very high counts, but they might not having any splenomegaly, hepatomegaly, and anemia. So probably we are dealing with the leukemite reaction. If the child is having the other parameters, probably we are dealing with the leukemia. And most of the times you might have seen in the reports, pathologists will mention as a left shift, right shift. What is this meaning of the left shift, right shift? Based upon the neutrophilic maturity, they will call it as a left shift. If they actually found in the peripheral smear more amount of the immature neutrophils, they call it as a left shift. This usually happen in the myeloproliferative neoplasms, particularly in the CML. In the children's, in chronic myeloid leukemia, what will happen? Lot of the monocytes, myelocyte, metamyelocyte, you will see in the peripheral smear. So the left shift terminology is nothing but more number of the immature neutrophils are looking at the peripheral smear. This is a 5 years old female child, developmentally normal, no significant past illness, brought with the complaints of unwell for 8 months duration, fever on and off, received multiple transfusions, elsewhere labeled as transfusion dependent pancytopenia. So this why I kept, if you see here, as I told UWBC and WBC, why it is important. If you see the counter mission, WBC count is 3,300, whereas the UWBC is 7,200. Which one to consider here? You have to always take as a WBC counter for us as a clinically important. UWBC is nothing but this child might be having some amount of the hemolysis. That's why like all the RBCs will be read as a UWBC. That's why UWBC count is very high. And this child has a hemoglobin of 6.1 and platelet count is almost 0. So we are probably dealing with the low WBC count, low RBC, and also low platelet count. So we are probably dealing with the pancytopenia. So this child has a pallor and icterus was there, no lymphadenopathy. She had a splenomegaly and no hepatomegaly with pancytopenia. So this child is having pancytopenia, but there is a discrepancy between the WBC and UWBC. So you must ask peripheral smear examination to have a corrected WBC count. And the routine workup we did, she had a retic count was the 4%, B12 folate was normal, PNH workup was negative because of pancytopenia. We did the PNH flow cytometry. Whenever there is a pancytopenia, if your vitamin B12 folate levels were normal, you must do the bone marrow aspiration biopsy to look at the factory problem, basically like bone marrow related issue. So this child had a 10% cellularity. How to know the cellularity of a individual? What is a normal cellularity? The simple way, how can we calculate? So you can just calculate 100 minus age is that particular person's cellularity. For example, a 10 years old child is coming. The normal cellularity for this child should be 100 minus 10 is the 90%. As the aging process is going up, our bone marrow is cellular component is replaced by the fat. So 10 years old child should have at least 80 to 90% of the cellularity. So this child is about like 7 years old child. 100 minus 7, so probably like you can see like 10 percentage. So the 90% cellularity should be there for this child, but this child is having only 10% cellularity, so that's why we call it as a pancytopenia. And then megakaryocytes also like this morphological megakaryocytes are there, and there were 3% myeloblasts are there, and her cytogenetics showed there is a trisomy 8. And stress cytogenetics we always do to basically rule out any pancytopenia child, inherited bone marrow failure syndrome, particularly Fanconi's anemia, so which is not there in this child. And NGS, no mutation was found. So this child probably we are actually dealing with the pancytopenia, that's called as aplastic anemia. Of course, we could able to found some of the erythroid series dysplastic changes and also megakaryocytic dysplastic changes. So we are probably dealing with the myelodysplastic syndrome in this kid. So this child is a myelodysplastic syndrome, refractory cytopenia of the childhood. So pancytopenia, how to evaluate after the CBC. So these are the various investigations you must do. And this is the pancytopenia evaluation chart with splenomegaly, without organomegaly. Without organomegaly, most of the times you might be dealing with the aplastic anemia or inherited bone marrow failure syndromes or myelodysplastic syndrome. Whereas the splenomegaly or splenohepatomegaly, probably you are looking at the leukemia, lymphoma, storage disorders. And this is another case, 3 years, 8 months old female child, sorry, male child, and petechial spots and nosebleeds from the 4 months duration, second degree consanguineous marriage, 2 abortions in the family, 2 siblings, there were no similar complaints, and he was on transfusion support both for the PRBC as well as the platelets. So he was having a pallor and also petechial spots. So based upon the history, you might be dealing with the RBC related problem and also platelet related issues. So bicytopenia you are dealing with. So the peripheral smear, if you look at, he has a low hemoglobin 8.9 and platelet count was at 10,000. WBC count 5,200 and absolute neutrophil count is the 1.4. So now we are actually looking at the bicytopenia in this picture. Whenever you are looking at bicytopenia, you also must know whether this child might be having, because he's also having anemia, he might be having a bleeding. So whenever the child is having a bleeding, anemia may come. So anemia may be a secondary effect of the low platelet count. So always you should keep in mind. So just look at the MCV. If the child is having a bleeding, what will happen? Most of the times, normocytic, normochromic anemia, you will see. So MCV is 88%. So what is our cutoff? 80 to 100 is our cutoff. So it is still within the range. So he has a normocytic anemia with a low platelet count. Here, the another important factor which I was telling is the MPV. Like MCV, how we utilize for the RBC related problem, MPV also in the similar manner we use for the platelet problem. And mean platelet, nothing but the mean platelet volume. The normal value of the mean platelet volume is the 7 to 10. So this is extremely useful when you are actually like dealing during the dengue season. So MPV during the recovery of the dengue fever, MPV will keep on rise. So if you are actually like monitoring the everyday CBC, if you look at the just MPV alone, you will realize. So this child has anemia, normocytic, normochromic, severe thrombocytopenia, normal TLC. So since there is a bicytopenia, we did the bone marrow. We found to have hypocellular marrow and decreased megakaryocytes. So decreased megakaryocytes means like factory is not functioning well. So your bone marrow is not functioning well. He says stress cytogenetics not sensitive to the mitomycin, flow cytometry negative for the PNH. So probably whenever there is a megakaryocytic lineage was not produced properly by the factory, probably we are dealing with the megakaryocytic thrombocytopenia, a megakaryocytic thrombocytopenia. So this child is having a thrombocytopenia. So he undergone the transplant. This is the another child. Most of the times we will be actually looking at the eczema, chronic skin allergy, but CBC is extremely important at these children's also. This is a 5 years old child. Recurrent skin eczema, bleeding from the skin lesions. Should have seen at least 100 pediatricians and at least like 50 dermatologists before coming to us. So she was developmentally normal, had extensive skin excoriation with the bleeding, almost like a nightmare night she had. And what is the differential diagnosis? So probably if she is coming first time, we might see her. She might be having a chronic skin allergy, asthma related spectrum, or she might be having a mosquito bite allergy. But mosquito bite allergy, we don't look at such a horrible kind of rash. And on physical examination, she didn't have any lymphadenopathy. She didn't have any hepatosplenomegaly, no organomegaly, developmental normal kid. Only the skin-related problems were there. So this is the CBC of the kid. If you see, the leukocyte count was 10,000 and hemoglobin was 11.6 and the platelet count was 2 lakhs. Now, if you look at the differential count, eosinophil count was 15 percentage was there, and absolute eosinophil count was 1,500. So this child is having a hypereosinophilia. So hypereosinophilia, skin-related problem, allergy, we all know frequently. They may present with the asthma, allergy, skin manifestations, so all these things. So when to actually like evaluate the hypereosinophilia? So hypereosinophilia definition is any patient having a absolute eosinophil count more than 500, which is persisting more than 3 months, then we label them as a hypereosinophilia. Then you need to work up further. Whether it is reactive hypereosinophilia or monoclonal hypereosinophilia, you must know. The simple test is the tryptase assay, but tryptase assay is not commonly being done in every laboratory. And the tryptase assay will tell us whether it is a reactive eosinophilia or non-reactive eosinophilia. And common causes in the developing countries, we all know that worm infestations are extremely common. And how would you approach? So the approach is this child, we did the further workup is immunoglobulin profile we have done. She had a 6,500 is the IgE levels, but other immunoglobulins profile was normal. And the flow cytometry basically to look at any like lymphocytic abnormality. There was the T cells were a little low in the number, but it was not so significant. Bone marrow didn't have any atypical cells. So she had a hyper IgE syndrome. And how to evaluate? As I told, simple thing is that tryptase assay is the first test to be conducted when you are actually dealing with the hypereosinophilia. This is the algorithm. And so this child undergone the transplant. If you look at 1,500 was absolute eosinophil count. Post-transplant, if you look at the absolute eosinophil count was 0. So this child is almost like 4 years post-transplant. She's doing well. And this is probably like last case, 8 months old child, born to the normal vaginal delivery, non-consanguineous, developmental delay was there. Basically, he came to me around like 8 months of age with a partial neck holding. Elsewhere, he was diagnosed as a congenital CMV at 3 months of age, and he was kept on valganciclovir for almost like 3 months duration. But they have not shown any improvement. He has not shown any improvement. He just came for the second opinion. When I saw him, if you actually if you see him, he has a right side cornea is small. He has a microcornea, and mother didn't give any like recurrent abortion. So I was just was suspecting probably he might be having some torch related infections. So he had a pallor, he had a microcephaly, right microcornea, short neck was there, and splenomegaly was there. Usually congenital CMV infection, we don't see microcornea. Probably rubella, yes. Microcornea CMV is an uncommon entity. And his CBC, if you look at, he had a 38,000 WBC count, 9.7 was the hemoglobin, platelet count was normal. So if you see the differential count here again, in this differential count, his monocyte count was extremely high, 16 percentage. Absolute monocyte count was the 6,100. So this is the peripheral smear will give us clue, or also counter mission in the graphs also will give us clue. So what we are actually dealing with in this kid, such a small kid, 3 months old kid, presented with the absolute monocyte count of 6,100. Probably we are dealing with a monocytosis. So how to evaluate the monocytosis such a small kid? We have to look at the any bone marrow related issue. So we did the bone marrow. He was found to have a juvenile myelomonocytic leukemia, basically. So when he came, his CME viral load was 800 copies, which is not so significant, doesn't warrant any treatment in a immunocompetent patients. BCR-ABL was negative. HB electrophoresis, HBF pattern will be pretty high in a JMML. So to just confirm in a criteria, we did the HBF levels. And NGS, of course, he had a PTPN11 mutation. Probably we all might be knowing that Turner syndrome, we usually see the PTPN11 mutation. So this child is having a JMML with PTPN11 mutation. So we have given like couple of months, 6 mercaptopurine, and then we transplanted him. Now almost like 2 years post transplant. This is a 6 years old male child, frequent fever on and off, history of blood transfusions for the 3 months duration. He had a pallor, short stature, hyperpigmented knuckle. If you observe him closely, he had hyperpigmented knuckle here, and no skeletal abnormalities. So if you look at why I actually like sharing this case. So if you look at the, don't look at only one parameter, because WBC count 4,700, hemoglobin is 10.7, platelet count is 20,000. So technically he has a, if you see just a WBC count, he has normal WBC count, but platelet counts are low, fairly low. Hemoglobin is 10.7, probably we take clinical practice as a low normal. So if you are actually not looking at the differential diagnosis, you may miss this child. He may die at home. So this is extremely important. Don't look at only the 3 numbers. You have to look at the further parameters also. If you look at the neutrophil count, he has only 1% is the neutrophil count. He has a just 50 absolute neutrophil count. So he is extremely at a high risk of febrile neutropenia. That's why the complete counter mission value you must look, not the just 3 parameters. So this child is having a bicytopenia or probably pancytopenia if you take the hemoglobin also into the consideration, and we need to work up further. So this child is having pancytopenia. What is the pancytopenia differential diagnosis? He has a short stature, he has a knuckle hyperpigmentation. So the first and foremost thing is MCV we should look at when there is a pancytopenia, because is there any nutritional vitamin B12 and folate? He didn't have any macrocytic picture. MCV is normal. So probably we are not dealing with the nutritional anemia. What else? Probably bone marrow is not functioning well. So we need to do the bone marrow examination. So bone marrow, he had aplastic anemia, and the PNH workup, of course, we do for every aplastic picture. So it was found to be normal. Whereas we have to rule out the inherited bone marrow failure syndrome. So you need to do the mitomycin SA. If you see here, he had a triradiate or tetraradiate pattern. So this is nothing but a Fanconi anemia. So whenever you are actually looking at a pancytopenia, whether you are dealing with the just immune-related severe aplastic anemia or inherited bone marrow failure syndrome. If you are not looking at the neutrophil count, these children will go home. They will have a 1 spike of fever. They may die because of febrile neutropenia. That's why you have to look at the complete CBC, not just at the 3 values. Then the platelet problems we'll see. This is a 16 years old mid-adolescent female. Basically, they brought to me for getting the fitness certificate for the ear surgery for the tympanic membrane perforation repair. And she didn't have any significant past illness. However, she gave history of the low platelet count since early childhood, but never had any bleeding manifestations. Developmentally normal kid, she's going to school, born to the non-consanguineous parent. So what are we dealing? Probably like she didn't have any RBC related problems. Means she didn't have any fatigue, she didn't have any exertional dyspnea, and also she didn't have any history of the recurrent infections also. So probably we might be dealing only with the platelet related issues alone. We are dealing in this kid. So on deep probing, she also gave history. Her father also had low platelet count, and father at 50 years of age was having a hard of hearing. Normally, the senile deafness we usually see at around like 60 to 70 years of age, but 50 years old gentleman is having a hard of hearing, and clinical examination was unremarkable. No family history of any kidney or recurrent infections. Why I have asked, I'll tell you. Why the kidney history I have asked, I'll tell you. So if you look at this CBC of this child, she had a 5,000 WBC count, hemoglobin was normal, platelet count was moderate thrombocytopenia. Look at the smear, there are like giant platelets were there, almost kind of. These are not the platelets, I'm sorry. These are the platelets. These are the platelets. And these are the neutrophils. These are neutrophil inclusion bodies basically. And here, why I kept this one, this graph. If you look at this one, platelet graph, this is not a normal graph. Normally, you see the peak at this stage, and but the graph usually ends very smoothly like this. But whereas the graph is extended up to 20 femtoliter, means you are seeing various sizes of the platelets in the smear, probably. So your MPV is pretty high. Probably MPV, so we are actually dealing around like a 10, 11. And MPV in this patient had a 13.2. That is a mission given value. So why this case is extremely important for us? And MPV is extremely important whenever you have a differential means like when you are dealing with thrombocytopenia, to differentiate whether it is a bone marrow related problem or the peripheral destruction. Whenever there is a peripheral destruction, bone marrow again tries to produce the more number of the cells. Those are the immature platelets are big in the size. That's why your MPV is very high. If the bone marrow or your factory is not functioning well, MPV is either it will be normal or it will be low. So to differentiate the ITP and the congenital is extremely important thing. Congenital, they might be having a lifelong history of thrombocytopenia. There will not be any change in the general health. They will not have much bleeding manifestations also. And whereas ITP is only acute onset, they might not have a prolonged history most of the time. So, and this is the slide extremely important when you are actually looking at the MPV. Based upon the MPV, the low platelet count differential diagnosis are these things. So the large platelet count, large platelets, somebody is having a MPV of more than 11. These are the some of the abnormalities. So this child had a basically May-Higlin anomaly. So why I have asked the kidney history, they might be having a Alport syndrome because they might be having like nephrotic syndrome. That's the important thing. And so this child had a May-Higlin anomaly. Then what I told to the ENT surgeon, I told them to look at the inner ear abnormality because she might her hearing deficit may not be recovered after even doing the correction for the CSYM repair, because these May-Higlin anomaly people will be having inner ear abnormality. Even if you correct, the hearing may not improve, so they may actually sue you. That's why like before actually like contemplating this kind of surgeries, we need to work up for the inner ear abnormality and we need to counsel the family. Otherwise, these are the medical legal important cases. So that's how like based upon the MPV, we will differentiate the various the platelet count related abnormalities. These are the various actual like graphs. Basically, for if you have interest, you just keep on look at the graphs, you will know. This is a 2 years old female newborn born by the emergency LSCS. Indication was a PIH and maternal gestational ITP. Well cried at birth, no perinatal events, on feeding. On day 3 of CBC, I'm going to show maternal blood group was B positive, father blood group was B. So there is no parental grouping difference. And mother had a gestational ITP. So these are the CBCs of this newborn child at various pages. I think this was actually like a day 1, and this was a day 2, and this is the day 3 of CBC. Why I kept this case? Whenever a mother is having a ITP, you have to do CBC of your newborn on the day 3 and day 5. At least 2 CBCs you should document, because the maternal antibodies will be transferred to the baby. These antibodies will cause the thrombocytopenia in this kid. So this is called as neonatal alloimmune thrombocytopenia. So this child had a low platelet count on the day +3. Why this is important? We all know that newborn children less than 50,000 platelet count, they are at high risk for the intraventricular hemorrhage. That's why you also have to screen for the neurosonogram to look at any bleeds. So the post IVIG, these are the platelet count on the day +5 of this kid. So I just kept this case mainly to know what is the differences between the neonatal ITP versus neonatal alloimmune thrombocytopenia. So to conclude, complete history, again, extremely important. Always ask for the hemogram. So one important thing I forgot to tell you, the CBC and hemogram differences. The CBC is the mission given value. If you are actually just looking at, we call it as a CBC. If you are adding the peripheral smear to the CBC, then it is called as a hemogram. So always you should know the normality before actually like interpreting the abnormal reports. Look at the complete CBC, not at the one parameter. Peripheral smear will give you most of the clues for you. So you are probably will get 80% of your diagnosis based upon the simple CBC and peripheral smear. RBC, always you should know MCV and RDW, which will help that picture, like what are the RDW and MCV related photograph you should must have in your clinical practice. And WBC count, of course, understanding of the histograms will help us extremely important information, which cell line defect you are dealing with even before doing the bone marrow examination. Platelets, of course, morphology and MPV will give us clue. Of course, start looking at the microscope. You always enjoy it. You should start looking at because you will see a lot of things. Thank you very much. If there are any questions, I can take it. Hello, Revan?
Yeah.
So any questions for anybody so that we can take
Any questions from the audience?
No, sir.
And next, what we will do?
So I think they taken everything or they not taken anything. That is what my
That's
doubt
what.
here.
That's what.
Sir,
What
excuse
we,
me, sir.
Revant, what we do?
Yes, sir.
I will send you a couple of CBCs for you. Okay.
Okay.
I will send tomorrow. I will go to the lab. I will just take some of the photograph and send it to you.
Okay.
Here across our team people, let them start interpreting. Okay.
Okay. Sure.
Those whatever the six. చెప్పండి.
సార్ కొన్ని కౌంటర్ మిషన్స్ టోటల్ డిసి అంతా అన్ని జీరో వస్తాయి సార్. సో అప్పుడు శాంపుల్ రిపీట్ చేయాలా లేకపోతే ఏంటి దాని ఇంటర్ప్రిటేషన్?
You need to look at the sample integrity also, కదా? Because
అంటే శాంపుల్ బాగానే వెల్ షేకెడ్ శాంపులే పంపించాం సార్ బాగా.
What was WBC count? What was WBC count?
సార్ WBC count is 7,000 సార్.
Then there might be some problem, with the machine.
Okay, sir.
So you should actually ask for the standardization of the machine.
Okay, sir. Okay.
At least it should give flags, no? With a 5-part counter machine, always will give flags.
Yes, sir.
Then immediately simple thing is to make a smear and look at the microscope.
Okay, sir.
Simplest way.
Okay. Sir, regarding immature platelet fraction, what's that role in CBC?
Yeah. So immature platelet fraction is nothing but your megakaryocytes, no?
Yes, sir.
So the immature platelet fraction, if most of the times what will happen for the 5-part counter mission, to have immature platelet fraction, you need to install one more software. Okay. Basically, immature platelet fraction will give us whether the large means megakaryocytes are like the big platelets are in the periphery or not.
Yes, sir.
If it is more than 10 immature platelet fraction, that indicates the bone marrow is recovering. That is the criteria we always will have in the dengue fever. No? So the simple way is you can actually look at the peripheral smear. Peripheral smear is showing the giant platelets. That is almost equivalent to your immature platelet fraction is more than 10%. So if you have one single peripheral smear, one large field, if it is showing 1 to 2 large platelets, it is almost equivalent to immature platelet fraction of more than 10. Only thing is immature platelet fraction nowadays everybody is using, but it's a little expensive. Almost each lab will charge about like 2,000 to 4,000 rupees. The simple way is just look at the peripheral smear and ask for the pathologist if there are 2 giant platelets in a peripheral smear, or before going to that, you can just look at the MPV, mean platelet value.
Yes, sir.
If the mean
which is more sensitive, sir? MPV or immature platelet fraction?
Immature is little more sensitive than the MPV, but MPV you must see from the day 1. Okay. For example, now what you do, if any dengue child comes, the day 1 CBC MPV, you look at day 3 and day 5, day 8. Then you will understand. Because clinician must be aware of these things, no?
Yes, sir.
If you understand the MPV, you don't require the immature platelet fraction. If you want to add the cost to the patient, so then probably you can do the immature platelet fraction.
So then what is the role in ITP regarding this MPV and immature?
The same thing. You are just looking at you are looking at the giant platelets.
Yes, sir.
Because ITP, what will happen? ITP, your factor is not a problem. There is a peripheral destruction of the platelet count.
Yes,
So
sir.
the bone marrow will produce more number of the platelets.
Yes,
So
sir.
during that process, what will happen? The
More
younger
metastasis.
platelet will be thrown into the periphery.
Yes,
Younger platelets are bigger than the mature platelets, no?
Yes, sir.
That's why you are looking at the peripheral smear.
Okay, sir. Okay. Thank you, sir.
Just look at the peripheral smear. Whenever you are free, go to the lab, ask pathologist, stain yourself, look
Okay,
at the smear. No, you will enjoy it.
Yes, sir.
And
Thank
one
you,
more
sir.
important thing is always never be rude with your pathologist. Always try to discuss with them, give them some clinical history.
Yes, sir.
Okay, that's extremely important. Revant, what I will do, I will share some 10 CBC reports tomorrow
Okay, Bhaiya.
and share among our team people.
Sure,
Again,
sure.
after 1 week time, I will keep those only 10 slides alone. We'll
Yeah,
just
yeah.
have a practice session so that how much they understood we will know.
Sure, sure.
We don't
Definitely.
teach them. It's only like interaction. One case, one PG can present it
Sure.
so that we can actually have a good discussion. Okay?
Sure, sure.
Yeah. Okay.
Next Thursday, పెట్టేస్తాలే భయ్య.
Yeah. Okay. No problem. I will send you tomorrow only.
Yeah, yeah.
But they will have a hands-on training.
Sure, sure. Thank you. Thank you very much for the exhaustive discussion, and thank you the participants for the patient listening. So we'll do that thing. We'll get the scenarios and CBCs from the sir, and next week we'll again meet you with the interpretation. If no further doubts, we'll stop the session.
Thank you, sir. Good presentation. Thank you.
Thank you, Amma. Thank you very much. We'll have a further discussion. We'll have an interactive session.
Yes, thank you, sir.
Thank you. Thank you very much. Thank you, Revan.
Okay, Bhaiya. Thank you.
Thank you.